leg, but then the anatomical model has both of his legs right now, and there's another one back there. So we can roll one of those up towards the front. So don't hesitate to go get a model if you're really just struggling with what you're palpating. So we have the obvious ones, which are going to be, so this obviously is the inside of the foot, this is the outside of the foot. So we have our medial malleolus and our lateral malleolus, okay? Those are going to be the widest points of the tibia and fibula, respectively. Together, those bones create the mortise, so that horseshoe is considered the mortise, okay? When you hear people say that they've had a high ankle sprain, that means that the tibia and fibula have separated, okay? So that's where these bones have separated and it's affected this mortise. The bone that sits inside that mortise is the talus, okay? And I know you've gone through all of these in anatomy, right? So to palpate the trochlea of the talus, you have to have the person in plantar flexion, and that's palpating the articular surface of the talus. Okay, so you go off the mortise anteriorly while they're plantar flexed, and you'll be able to palpate the trochlea. Now, when you hear people say that they maybe had a trimalleolar fracture, it's that they've fractured the trochlea of the talus in both of their malleoli. Okay, so the trimalleolar fracture is these two, and then the trochlea of the talus. Now, if we stick with the talus, there's a thinner part here, and then it gets thicker again, more distally for the talus. That thinner part is called the neck, and the thicker part is called the head. Okay. Now, the head of the talus is going to be important, and over here, and this is going to be clearer when we get to a live human. This is called the sinus tarsi right here, and we're going to have our hands here when we're looking for a neutral position of the foot. But again, this one will be more obvious when we get to a human. If we stay on the medial side of the foot, we go off the talus. The next bone is the navicular. Okay. Now the navicular is going to have a protuberance right on that medial side, and sometimes that protuberance is used to measure how flat the arch is, and so you can measure, it's called the navicular drop, and you measure the distance from that protuberance to the ground. Okay. It's also the attachment point for the spring ligament. Okay, so it's a ligament attachment site. If we continue to go distally, we're going to hit the cuneiforms. So they're not very originally named. So we have our medial, middle, and lateral cuneiforms. Okay, and then we've got our cuboid over there. But if we're staying medial, we have our medial cuneiform, which then goes to our first metatarsal. At the head of our first metatarsal, we're going to have two sesamoid bones. So sesamoiditis is pretty common in the first ray. These sesamoid bones are embedded in the flexor digitorum brevis. Okay, flexor pollicis brevis. Sorry, flexor pollicis brevis. Hallucis. Wow, it is not a thumb. Thank you.
It is if you replace it.
Yeah, right. Yeah. So
it was a good joke, okay, Aubrey?
So you laughed. So similar to the hand, we only have 2 phalanges in the great toe, whereas we have 3 phalanges in all of the other toes. Okay. So if we go back to the calcaneus, if you see, the calcaneus makes a shelf under the talus on that medial side of the foot. Okay, can you see that? This is called the sustentaculum tali. It's the other attachment of the spring ligament. We also are going to have some muscles that run under that shelf. So it's going to be important to be able to palpate that shelf. Now, I was remiss in our talus on the medial side. We also are going to have the tubercle of the talus, which is going to be in the back. Okay, and it's going to be an attachment site for the deltoid ligament. So we're going to have to find that talar tubercle on our person too. Okay, so we've talked about the medial and lateral malleoli, creating the mortise, We talked about the trochlea of the talus, the neck of the talus, the head of the talus, and then the posterior tubercle of the talus. We went on to the navicular and the navicular tubercle, medial cuneiform, the base of the first ray, the sesamoid bones at the head of the first metatarsal, and then back on the calcaneus, we had the sustentaculum tali. So if I could have a barefoot Amy.
Okay. Maybe this one. I don't have a toenail on the other one.
Which one?
And how Amy is sitting is how some people will be comfortable because it lets their knee be bent. So that is good. And I'm gonna have you face the other way so that the medial side of your foot is facing the crowd. Okay.
Alright, guys. How many views am I blocking if I'm sitting right here?
Oh, perfect.
So,
Sorry, Emily.
so our lateral malleolus is going to be lower than our medial, more distal than our medial malleolus. So there are malleoli. If we come forward, there is the mortise. If I go into that mortise, I'm now on the talus and I'm on the trochlea of the talus. If I come medially, I'm going to be on the neck of the talus, and then as it comes back out, I'm going to be on the head of the talus. Now, Amy has a lovely navicular tubercle, so it pops right out for us. So can you see it? If I pull her skin a little tight, you can see it right there. If we come forward a little bit, we're going to be on her cuneiform, and then I'm on the base of the first metatarsal, and I come down, and then if I palpate down here, I'm going to feel her sesamoid bones right here and here, down there, and then her phalanges. Okay. Now for the sustentaculum tali, here's her navicular. We're going to go more posterior, and that ridge right there, I'm on her sustentaculum tali. Okay, so now I'm pulling up right there. Copacetic?
Is that part of the calcaneus or the talus?
It is the calcaneus. So if you look at the model, the calcaneus actually creates a shelf that the talus sits on top of. Okay?
Sustains the talus, if you will.
Yeah.
Oh, I see it.
Oh, that's what the bolt goes through. Okay.
Yeah. Okay. Now we defined the talar, the tubercle. Again, it's going to be that posterior attachment of the deltoid ligament, so it's going to be right there. Now, you can break the deltoid ligament into 4 parts. We're not going to for this class. It's just going to be the deltoid ligament. So that's the medial ligament of the ankle. So it's going to come off the medial malleolus. It's going to attach to all the structures across the talus and the calcaneus. So it's all going to be in this area. So if you suspected someone with a medial ankle sprain, you would be palpating just distal to that medial malleolus, okay, and looking for swelling in there. All right, so that's one soft tissue structure that we can cover when we're on this side, is that deltoid ligament on that side. Now the spring ligament is going to be going from that navicular over to the sustentaculum tali, and so that's not super comfortable, but it's right there on Amy, okay? So I think we should stop there and start with the medial structures. So we covered a lot of the structures on the medial side of the foot. So we're going to move on and cover some of the other tarsal bones. So we've talked about the medial cuneiform, and that's going to progress on into the first ray. The middle cuneiform is going to go in with the second ray, and the lateral cuneiform is going to go into the third ray, okay? The cuneiforms are uninteresting, okay? There's not a lot that goes wrong with the cuneiforms. Similar to how we had the hamate connect to digits 4 and 5, our cuboid attaches to digits 4 and 5 in the foot. Now, there's going to be quite a divot. So the base of digit 5 is going to be quite prominent, and then it's going to fall into that divot of the cuboid. So it'll be very easy to find the cuboid laterally, okay? Now, on the calcaneus, I guess I should go this way for you guys, sorry. On the calcaneus, there's going to be a protuberance that we call the peroneal tubercle, okay? A couple of things happen there. Our extensor fascia, our extensor retinaculum, attaches there. we also have our peroneal muscles that are going to go around that. So we can have a compartment syndrome with the fascia that attaches there, and so sometimes they'll go in surgically and release that there. So you need to be able to find that peroneal tubercle, and that's on the calcaneus. Now, for ligaments on the lateral aspect of the ankle, we're going to have 3, and we are going to separate these 3 because they can be torn separately or together with lateral ankle sprains. Lateral ankle sprains are more common than medial ankle sprains partially because the fact that the lateral malleolus goes down more inferiorly, so it's easier to roll your ankle in than it is to roll your ankle out. So for our ligaments, we're going to have our anterior talofibular ligament, so it's going from the fibula obviously to the talus. We're going to have our calcaneofibular ligament, which is going to go from calcaneus to the fibula, and then we're going to have our posterior talofibular ligament, so it's going from posterior talus back up to the fibula. Now, you can most commonly you're going to tear your ATF first, then your CF, then your PTF. In rare occasions, you can actually go PTF, CF, and then ATF, but most commonly it's anterior to posterior. And so you need to be able to palpate all 3 of those structures to see if one's more tender than the other. To palpate those ligaments, you're not going to feel a specific structure. You're simply palpating distal to the lateral malleolus, anteriorly, directly, inferiorly, and then posteriorly. Okay? We haven't talked about pulses, but there are 2 pulses in the foot that we're going to be palpating. One is the dorsalis pedis, which is going to be usually between the 2nd and 3rd ray. Sometimes it can be between the 1st and 2nd ray, but over the tarsals. So that's the dorsalis pedis. And then we're going to have our posterior tibial, which is going to be on the medial side, and you're going to follow up that medial malleolus and feel it posterior to the tibia. Okay, so those are our 2 pulses for the ankle. Now, that made me think of something else. Oh, we didn't talk about the tibia a whole lot. So we have this anterior edge, and then we have the medial edge right here. And our several of our ankle muscles are going to attach to both of those ridges. When people talk about anterior shin splints, they're going to have pain along that anterior edge, and medial shin splints is going to be having pain along that medial edge. Okay, so that's why it's important to palpate those as well. Okay, so for lateral structures, we have lateral malleolus, we have our anterior talofibular ligament, our calcaneofibular ligament, our posterior talofibular ligament, we have our peroneal tubercle on the calcaneus, we have the cuboid, which attaches to ribs. Oh my goodness. Phalanges or metatarsals 4 and 5. We have the base of 5, which is going to be very prominent. Okay, so let's go ahead and palpate. And then we have pulses, sorry. We had dorsalis pedis, which is on the top part of the foot, and then posterior tib, which is going along the back. We actually have covered the list pretty well. So there's just a few other structures that we haven't covered. So I had shown you the sinus tarsi on the skeleton, but I didn't come back and show it on a person. So when we measure, we talked about the talocrural joint, which is going to be the talus and the mortise is the talocrural joint. Then there's the subtalar joint, which is going to be the talus and the calcaneus. And we're going to be measuring that posteriorly. We're going to care about finding subtalar neutral. And so we're going to need to be able to put our hands in the sinus tarsi on this side, and that's just that divot, okay? That's more obvious when you're looking. So if you look over, for those of you who are on this side, that would be the sinus tarsi right here, okay? Then our other hand is going to be on the neck of the talus. So those are going to be our 2 landmarks when we're looking for subtalar neutral when we start to do our goniometry, okay? So I just wanted to point out sinus tarsi because I had not done it on a human. Now, I know the skeleton is a human too, but not anymore. The extensor retinaculum is going to cover both the anterior aspect of the leg and then also the top of the foot. And that works just like the retinaculum that we talked about in our wrist. If we didn't have that retinaculum, when the dorsiflexors contracted, we wouldn't actually get that pull. So they're holding those tendons to to our limb. Okay, so just know where the extensor inocula is. Then our last one is, the next one, not last one, is plantar fascia. Somehow I forgot about that one. So that's obviously on the bottom of the foot. And so when you're palpating that, you're going to want to put the person in dorsiflexion and then extend the toes. And then you're going to start at the heel and work your way up, okay? And by extending the heels, I don't know if you can see, if I have his foot here on slack, there's not much tension there. But if I extend his toes, then it gets to be very taut, okay? So that is, are you doing okay?
Yeah, people are giggling.
He's just like sitting there like smirking and staring.
Anytime I need a foot massage.
So that's going to be the plantar fascia, and of course you've heard of people with plantar fasciitis. Plantar fasciitis is really difficult to treat because we can't really rest it. You know, if people are mobile, they're on it. So plantar fasciitis is really a tough diagnosis to have people come in for. And then Gabe, do you mind rolling onto your stomach, please? So, and slide down towards me. So we have a couple of more bursa. And so we have two bursa that we need to talk about. So we have our calcaneus. So obviously our gastroc tendon is going to be attaching to the tubercle of our calcaneus. And we're going to have two bursa. We're going to have one bursa that is between the Achilles tendon and the calcaneus, okay? And that's the retrocalcaneal bursa. And then we're going to have a bursa that sits on the outside of the tendon, okay? So we've got one that's anterior and one that's posterior to the gastroc tendon. So again, if there's no swelling there, we're not going to feel anything there, but I wanted you to remember to know where those were, okay? So we covered sinus tarsi, we covered the tubercle of the calcaneus. Now, there's also where the plantar fascia attaches, where if you've heard of people who have heel spurs, typically heel spurs occur because there's too much pull on that plantar fascia, because again, bone forms based on imposed demands, Wolff's Law, and so those heel spurs are going to be where that plantar fascia is attaching to the calcaneus, so you'll want to be able to palpate there as well, okay? Dr. Bryant, was that it? I think that was what we covered. Okay, so let's go ahead and